A kind introduction, and I have put together some slides that I will try to go through in 15 minutes. So thank you for your time today that you guys are tuning in, and hopefully we can all learn a bit more together. So maybe we'll go to the next slide, which I'll do by myself. Is that control now? Oh, there it is. Excellent. Okay, so I have nothing to disclose. No one pays me anything extra. And I'm hoping today we can define and learn an approach to the assessment of pain, distress, neuroirritability in children who have severe neurological impairments and communication impairments, and that we'll understand when and how to use a few reliable and individualized pain assessment tools for nonverbal children and youth. So just to touch base quickly, severe neurological impairments of the CNS include a variety of etiologies. It's by definition intellectual disability. They often, in the severe range, they have limited verbal communication. They may have coexisting motor impairments like cerebral palsy. It includes autism spectrum disorder. And what's interesting about this group is that 90% report recurrent pain more than in a year, and 75% at least weekly, and about 50% will have pain episodes for more than 9 hours. So I think the take-home consideration is that this is a mixed group with many different etiologies and medical, physical health factors, and as a result, they also have varying and atypical expressions of pain based on their developmental communication abilities. I want to highlight Howard 2017, the pediatrics article that was published as a guideline about pain assessment. A lot of what I'm talking about comes from that article, so if you're interested in more, it's a reference at the end. So one way to start is thinking about how important it is for us to assess communication abilities and pain from a developmental age lens. And as people involved with children and youth, we encounter this all the time. So we look at just the chronological ages. And if we look at crying in an infant, we know that crying can sometimes be a sign of discomfort or distress. Maybe they're hungry, maybe their diaper's wet, or sometimes it could be something more serious. They could be in pain. We could be worried about an infection somewhere that they can't tell us about. And there's different cries as well. So parents, for those of you who are parents, there's different cries, right? When the baby's in pain versus they're bored versus, they're complaining or fussing about something. So those are all just important concepts to think and how we can relate that to our patients. So when we see our patients, we want to get to know them, and often we start interacting with them. We'll call their name, we'll try to maybe greet them or offer a toy with them, and how they respond, whether they respond, it gives us a sense of what they know. But the gold standard is usually asking the caregivers who knows the patient very well about their receptive and expressive communication. Are they using gestures? Are they mostly, nonverbal? Things like facial expressions and vocalizations. And at the end, you're trying to get a sense of, is my patient at a level where they're pre-symbolic, so that would be mostly using nonverbal vocalizations. Are they symbolic, maybe using some gestures, using pictures, pointing symbols, or are they mostly verbal? So those are all kind of the general approach, but then the very important, this is like the big money question that I ask families and caregivers is that, after there's a known painful incident, needle, fall, scrape their knee, post-op, how did your child respond or behave? Because it's only when you have, that's kind of like a gold standard. You see something painful happen, and then you say, okay, this is the child's, kind of behaviors after that in response or communicating perhaps their experience of pain. So every parent will tell me something different. Some say, mostly it's crying. Some, will give a bit more detail that they're able to point or localize pain. And then some can be very verbal about it. So in terms of common pain behaviors, we want to look at vocalizations, facial expressions. Can we console them or not? A lot of these are in the tools that I'm going to go over later. Their movements, how does it affect physiologic parameters like heart rate and sleep? And then the big question is often asking, is there a change in these behaviors from baseline? And often for families, it's trying to decide, well, when did that change occur? Is this quite an acute issue that I'm dealing with and I want to think more about acute causes, or has this been happening for a few months? And it still could be a nociceptive, physical health disorder that could be diagnosed and treated, but it's maybe going on for a while. And we're trying to get to the bottom line question is, how does this patient specifically communicate pain or distress? And we want to be aware of atypical features in this population. So it could be blunted facial expressions instead of crying. It could be laughter or breath holding or self-injury. So when I see an individual and then they have this distress or pain or self-injurious behavior that's non-specific, then it's always important to think for this population, is there a change in environment and increased stress? This is probably the most common thing. So we've all been going through COVID, the ups and downs, and depending on that situation or whether there's been changes in the school or the teacher or the routines or the demands placed on the individual. New isn't always better, so always keep that in mind. And then you want to think about developmental contributors. So in our clinic, we always think, if we can improve communication and decrease frustration, we will almost always improve the behaviors or the irritability. So this can be treated with augmentative communication. There's physiologic contributors for all of us. When we're not sleeping well, we're hungry, we get a bit more irritable, we're more frustrated easily. So you want to make sure that poor sleep is a common issue with this population for different reasons. And acute nociceptive pain obviously is an important goal to always think about in these presentations. And then lastly, neuroirritability. This concept that's defined in Hauer et al. As persistent or recurrent episodes with pain or distress behaviors after assessment and then management of nociceptive sources. And then the query is whether the central nervous system is the source of the pain. There we go. So I added this in because I have a chance to work with behavioral analysis analysts, and they are very helpful. I think they're a very helpful investigation or test, kind of how we sometimes visualize, MRI or doing a blood test, for an ESR or an infection to localize infection. The behavioral analyst is very helpful to analyze the behavior to think, well, is there a function to the behavior? So what this entails is careful observations of the environment, so physical environment and also sequential, so what's happening with time and what's in the environment. And the ABA kind of applied behavior analysis terminology is antecedent and consequence, before kind of the pain or distress behaviors. And they're able sometimes to do something called a functional analog, which is an experiment with different environmental conditions to look at the function of the behavior. So for example, is the function and to get access to a preferred item or activity? Is it to escape from demands, a task that the child doesn't like cleaning up? Is it to get social attention from the caregiver? Or is it sensory? Is it a response to internal stimuli? So maybe pain or discomfort, and then they're crying or the behavior comes out. Or maybe it's a behavior that they actually enjoy, and the behavior itself is reinforcing because it helps maybe decrease stress for them or it feels good. So if the function is sensory, I tend to then think that it's mostly not dependent on the environment because it's not dependent on the antecedent and the consequence. And then medical investigations or medication trials should be considered. So some assumptions that interfere with identifying pain are good to think about as we're doing these assessments. Sometimes pain is under-identified where there's atypical presentations that caregivers don't pick up, or people attribute it to the child's autism or intellectual disability diagnosis. Sometimes we can even label conditions too quickly, like neuroirritability or agitation, and we shift away then for thinking about pain and looking for causes and treatments. Sometimes we get increased tone and movement from spasticity, and maybe it's not necessarily the pain that's causing it. And sometimes we also give labels to kind of the behavior, and then that moves us away from pain if we just talk about stiffening or tension or rigidity and not thinking how those could be pain as well. And then less common is over-identifying pain. So some caregivers will, have the child cry a bit, and they'll think, oh, the child's in intense pain, or maybe the child is just trying to get access to, their favorite toy, or they're hungry. And so sometimes, depending on, the caregiver's experiences, we kind of need to work that out. So I was going to move through now just quickly some different tools that give us, I think, a good approach. These tools give us a sense of a clinical approach to assessment. So I'll talk a bit about the revised face leg activity cry consolability scale, where there's scores of mild, moderate to severe pain. There's the individualized numeric rating scale. There's the non-communicating children's pain checklist, both the post-op version and the revised version. And then there is, some important considerations like the degree of individualization we can bring about for each child and taking into account the parent knowledge to inform us. So this is the revised FLAC scoring, where it's quite simple. You have 0, 1, and 2 in each of these different domains, and you can circle them and score them. So that just gives you an example. And sometimes with this one is an example from their research studies where they wrote down individual comments that parents would write as they filled out the scale. They write this at the bottom, and I think this is very helpful information for the clinician to then, compare with the child. So if they're in an inpatient and they're post-op and they're recovering, then this is great for the nurses to know, and also good for other caregivers to kind of think about. And so this moves us towards, can we create a graded continuum of individualized pain behaviors, which one of the scales, the individualized numeric scale, kind of talks about. Sorry, I'm pressing in sometimes. Oh, are there little lines there? Okay, there we go. So with this scale, you could see, you're creating it for each child, where 0 is no pain, 10 is the worst, but then you're putting very specific individualized things along the scale, so that then we can really calibrate it to that individual. Non-communicating children's pain checklist, it's scored out of about 90. So there's 30 items. They can be, just a little, fairly often, very often, or not at all. And it goes through different domains like vocal, social, facial, activity, body and limbs, physiological, and then eating or sleeping. And then you can see the scores, the categories, you add up the total. And I think I had the cutoffs, in an earlier slide where the post-op had a cutoff at about 11 and the revised had a cutoff at about 7 for pain. So acute nociceptive pain is kind of our first goal as physicians or health professionals. Even as parents, we want to figure out, is there something that we can identify and treat that could improve the situation? And so you pretty much, the take-home message is head to toe, right? You think head to toe and you're going through all the common areas that you might see a problem. And there is a nice little table I put in there from Howard et al. Where she talks about different aspects to examine and then for what pain source to kind of look at. So that's helpful. So in terms of chronic pain, this is something where it's long-standing irritability, could be on and off these episodes, and we've tried to look for common problems like GERD and spasticity. And we've also, considered problems of the CNS that are sources of pain that we would need to maybe treat differently. So central neuropathic pain, visceral hyperalgesia, autonomic dysfunction, dystonia, spasticity, muscle spasms, delirium. And the important thing is that more than one of these can coexist. And so Howard et al. Goes through some nice kind of definitions, descriptions about each of these in more detail. So spasticity, tone, and cerebral palsy can contribute to pain. So I stopped kind of being involved in this area when I started specializing in intellectual disability at Surrey Place, because we take care of less people with cerebral palsy there. But I know at Holland Bloor, where I trained, they've developed a nice toolkit, about looking at the pain toolbox for individuals who have hip subluxation or pains from their spasticity, and so that's useful kind of for you to be aware of. So I'm on a slide now about irritability versus neuroirritability. And as a developmental pediatrician, we're very aware of irritability that's defined in the ASD-IDD literature, where atypical antipsychotics like risperidone and Abilify have been shown to decrease irritability in randomized controlled trials. So irritability is defined in this case by the aberrant behavior checklist irritability subscale, which includes items like aggressive behavior, self-injurious, yelling, screaming. So it's very non-specific kind of behavioral descriptions, and it comes up into an irritability score. Now, the reason this is a challenge is because there's, as I mentioned earlier, there's different functions for behaviors. Sometimes children have these behaviors because they want the candy that mom has said, no, you can't have. And so if the function is for that, then we're less worried that, medication, or it's less likely that medication will improve the situation that much. So often this kind of irritability refers to increased anxiety, states of increased anxiety and stress, emotional reactivity to changes in environment. So maybe difficulties with transitions, with small demands. Now, neuroirritability, I was thinking, from my experience, maybe it has the issue where nociceptive contributors have been assessed and managed, and there's still a lot of these behaviors. It's maybe not as dependent on the environment. So it's not because they just saw the candy bar or someone asked them to do something, but it kind of comes out of the blue, maybe with that sensory function. And perhaps they're emotionally reactive and upset for a long period of time. And they're very difficult to calm down. So perhaps that's, a better kind of definition of that. And if that's the case, then, in terms of trying to address and treat, just trying to get to my next slide. There is a treatment of neuroirritability with the WHO analgesic ladder, which was modified a bit by Hauer in 2012 to the neuro pain ladder. And she, talks about the empirical selection of meds for persistent pain behaviors, mostly using the criteria of safety, because there's not a lot of evidence and it's empirical, and then information on efficacy and some evidence from adult studies. And so then she has, these three tiers where maybe gabapentin, has is the safest and has some support. Maybe then trying something like tricyclic or methadone or clonidine, and then um, consider treatment in parallel while considering more invasive testing to figure out, an etiology or surgery. So I just put these at the end here as examples for, from her article where she put some information about gabapentin, about the tricyclics, uh, and it just goes through a bit of her protocol and some nice dosing guidelines there for us. And then similarly, she does this with the clonidine. And I just wanted to highlight clonidine because in my population, I'm often seeing individuals who have hyperactivity impulsivity, which is an indication for clonidine. But I also see this emotional reactivity, difficulties with sleep. Um, just trying to get to the next slide. There we go. So she gives very specific dosing kind of recommendations for clonidine, which I thought was very helpful because it's good to know kind of per weight kind of what we should be doing instead of just going by the numbers of like 0.025 and then increasing up to the 0.1. So I just wanted to end kind of with those things and then maybe have time